go with needle decompression to try to aspirate some milky fluid from this nucleus. Now it didn't come out because I was not penetrating the needle deep enough. So what happened? There is like still high intralenticulaar pressure. The capsular excess edge is trying to run out. So I pulled out immediately, added more viscoelastic, and took my needle back and penetrated deep in the nucleus and the cortex. Only then the milky fluid came out. That's it. The bubbly milky fluid is actually milky nucleus matter. So what happened in this case, that I did not at first I did not go like deep down in the nucleus, and I thought that the milky fluid is only like trapped in the bag, which is most of the cases. But sometimes these milky cataracts can fool you, and the fluid is not trapped in the bag, but rather within the nucleus and the cortical matter. So you really have to go deep down, and don't get fooled, and don't get confident if you don't get good aspiration at first, because you probably don't penetrate, or you're probably not penetrating the needle deep enough in the nucleus or the cortical matter. So with a little technique and good shearing technique and aiming for small rexes, we were able to run the rexes 360 and then aspirating the nucleus and the cortical matter with the epinucleus mode, because it was very, very soft. No hydrodissection was made in this case because you cannot see the fluid wave, and the nucleus is very, very soft and kind of milky, so it was easy to aspirate. The rest of the case is being carried out routinely, thankfully. Like, there is no extension and there is no rupture. Loading the IOL with the taco sandwich technique, tucking both haptics in over the optic is being done after creating a fold in the optic. Of course, after filling the AC with viscoelastic and dilating extending the main wound to accommodate the large cartridge. And yeah, so here is the taco technique, tucking the haptics over the optic and then loading it at the cartridge, making sure that the AC is full of viscoelastic, stabilizing the globe with the chopper on the side port, and the lens is going into the bag, and then rotated and centered with the chopper. Use a second instrument if needed, and then the rest of the case, like, we're gonna do some good washing of the viscoelastic and hydrating of the side ports and the main wound. So if you notice, the red reflex is terrible in this case. The vitreous looks ugly, turbid, muddy, and from the patient's history we know that he had white cataract and he had poor vision from early childhood, but he doesn't know the reason and he doesn't have medical records with him. On a B scan, on physical exam we saw the white cataract, but in the B scan the retina was flat and some condensation in the vitreous without any specific ongoing inflammation or infection or detachment. So we decided, after removing the cataract, to do exploratory hospital vitrectomy. So here's a vitreoretinal surgeon is taking over the case now, and after placing sutures in the main wound, as you can see, there is a lot of debris and condensations in the vitreous cavity, especially near the trocars that inserted in the pars plana, and inspection of the posterior segment showed that sclerosed vessels all over, and pale optic disc, and very dirty vitreous, but thankfully there is no detachment or there is no ongoing active infection. So decision was made to remove the vitreous, clear up like all the inflammatory debris, and condensations, and then put a tamponade and inform the patient that the visual prognosis is not that great because the vessels are already sclerosed, and but we gave the patient the best chance of this corrector visual activity in this case by removing the cataract and clearing up the media. Thank you so much for watching this case, and have a great day.